Hello, Introductory Psychology students, and thank you so much for joining me for this video. In this video, I'm going to start our discussion of clinical psychology and psychiatry, and we're going to kick things off by discussing kind of an introduction to psychological disorders. So this is going to review Module 47 of your textbook. Okay, so we'll start with just a basic definition of what psychological disorders are, and then I'll kind of break down some of the key terms within that definition. Okay, so psychological disorders are defined as patterns of thoughts, feelings, or actions that are deviant, distressful, and dysfunctional. Okay, so there's a lot of jargon in that definition, and some of the words that we use are very loaded terms. So what I'm going to do is break down some of that for you. Okay, so first, when we refer to a disorder, we're talking about a state of mental or behavioral health that is maladaptive, right? So why do we use the word disorder? Well, we use the word disorder instead of disease because the latter term typically implies a known cause of the symptoms, right? So in naming a disorder, we're essentially naming a collection of symptoms that tend to go together, right? So if we were talking about symptoms like low self-esteem, feelings of hopelessness, maybe feelings of wanting to harm oneself, right? We would label that disorder as depression. Okay, so what about patterns? Well, when we say patterns, we essentially mean a collection of symptoms that tend to go together and not just a single symptom, right? So a pattern versus a single symptom. One of the symptoms of brain cancer, for example, is a headache. If you have a headache, though, it would be a mistake to assume that you have brain cancer, right? Similarly, one of the symptoms of major depression or major depressive disorder may be that you feel sad, right? If you feel sad, though, this is not enough to qualify for a diagnosis of major depressive disorder, right? You might just be sad because of a movie that you watched, or sad because you have recently broken up with your significant other, right? So single symptoms by themselves are not indicative of psychological disorders, but rather patterns of symptoms, and usually patterns of symptoms that persist over time. Right? So let's talk about distress and dysfunction, right? So generally when we talk about distress and dysfunction, we're referring to symptoms that must be sufficiently severe that they interfere with daily life and well-being, right? So distress essentially means internal or emotional anguish, and dysfunction means that the impact of the psychological disorder is such that it affects a person's ability to manage day-to-day tasks, right? To manage relationships, right? And maybe even to function in one's vocation or one's job or in academic context, right? So, for example, severe depression or anxiety may prevent someone from feeling able to go to work or school, and personality disorders might create persistent problems in relationships that result in dysfunction there. So we're going to talk more about deviance in the next slide, but another common term is abnormal, which more literally means varying from the norm, right? Both of those terms have acquired kind of a negative connotation outside of the field of psychology. So let's go ahead and look at them closer. Okay, to deviate in general means to vary from what we would expect to typically happen, right? So in psychology, a behavior or mental state is considered deviant by the particular culture that one subscribes to, right? So we say that a behavior or mental state is deviant when it's different from what would be expected in that culture. And a disorder may also be a deviation from a typical developmental pathway, right? So deviation from a developmental pathway might include things like autism or intellectual disability, or even just an extremely disruptive behavior which persists in all situations, right? So to deviate from the norm is not enough, though, to define a disorder, right? So just because you deviate from the norm doesn't mean that you would be diagnosed with a psychological disorder, right? The onus, or the most significant aspect of the disorder component, is that your deviant behavior or deviant mental state has to have a profoundly negative impact, either on your ability to work, your ability to form healthy relationships and maintain healthy relationships, your academic context, anything like that. So it's not enough to be deviant, right? There has to be that dysfunction component as well. Okay, so again, the particular context of the deviant behavior and the particular culture that an individual is in is really going to dictate how we define deviance, right? So context would be whether a behavior varies from expectation, right? So that would tell us whether a behavior is deviant or not, right? So yelling for hours is not deviant if it happens, for example, at a sporting event, but it would be maybe in other contexts, like a classroom or, out in public or something like that. Culture, right, is going to dictate this as well. So, again, painted faces might seem deviant when viewed from a different culture. However, if it's at a football game, people paint their faces often and it sort of fits in with the appropriate context of a sporting event, right? But it might be considered deviant in other situations depending upon the culture that you subscribe to. So the medical model is the model that psychologists use when it comes to diagnosing and treating psychological disorders, right? So the medical model assumes that psychological disorders are mental illnesses with physical causes that can be diagnosed, treated, and in most cases cured through therapy, sometimes in a hospital, and also oftentimes with medication as well, right? So the medical model not only suggests a particular course of treatment, right, and a particular diagnosis, it also tells us something about etiology or the cause of mental disorders, right? So it's not always possible to determine the cause of a specific mental disorder, right? But in general, the assumption is that the cause is physical and mental, not spiritual, right? So throughout psychology's history and early medical science, right, people did things like drill holes in the skulls of individuals believed to be suffering from mental illness. And the idea is that drilling holes in the skull would allow evil spirits to escape, thereby curing the person of their mental illness. But obviously, that is not the contemporary view of mental illness. The medical model says that the cause of mental illness is physical and can therefore be treated within the body, right? So again, psychological disorders are seen as what's called psychopathology, or an illness of the mind. And disorders can be diagnosed, labeled as a collection of symptoms that tend to go together, right? So because we have this collection of symptoms that we've defined, or these patterns of behavior that we've defined, we can diagnose psychological disorders, and people with this disorders can be treated. They can be given therapy and medication and other interventions designed to restore mental health. Okay, so why is it that we want to create classifications of mental illness, right? Or what is the value of talking about diagnoses instead of just talking about individuals? Well, one benefit of classifying psychological disorders is that we can create a kind of verbal shorthand for referring to a list of associated symptoms, right? So what research has demonstrated convincingly over time is that often particular symptoms are like constellations, if you will, in that they always seem to appear together in relatively consistent patterns, right? So by looking at these patterns and naming those patterns of behavior, we can essentially give ourselves a shortcut, if you will, to denote all of those symptoms together. And our diagnoses also allow us to, it also stimulates research, right? So diagnoses allow us to statistically study many similar cases, which allow us to predict outcomes, right? So if we can study many different individuals or groups of individuals who all show these consistent patterns of symptoms, right? That allows us to come up with different interventions and predict maybe some of the factors that make people more vulnerable to psychological disorders, and also predict the outcomes or how successful some of those treatments are. Okay, so again, the way that clinical psychologists go about diagnosing psychological disorders or classifying them is they use something called the Diagnostic and Statistical Manual. So this is abbreviated as the DSM, and we are currently in our 5th edition of the DSM. And essentially what the DSM does is it provides very clear definitions of particular kinds of disorders, right? So we talk about delusional disorders like schizophrenia, anxiety disorders like generalized anxiety disorder or PTSD. We talk about mood disorders like major depressive disorder and seasonal affective disorder and bipolar disorder, right? So the DSM gives us very precise and consistent patterns of symptoms that we look for a given disorder, as well as how long those patterns of symptoms have to persist and in what context before an individual meets the criteria for having a particular disorder, right? So again, the benefits of having something like the DSM or the Diagnostic and Statistical Manual is it's easier to understand the incidence or frequency of things like autism if we have a clear definition, right, of what autism is and the symptoms and patterns of behavior that are consistent in individuals with autism. Okay? The DSM is also really important in terms of the logistics of treating individuals with psychological disorders because we can work with insurance companies, for example, and make sure that they pay for particular services and they're more willing to do that if there's a particular diagnosis that's available. Okay, and the other benefit of using the DSM is that it is consistent with diagnoses used by medical doctors worldwide. Okay, so in order to make the definitions clear, each diagnosis in the DSM, like I said, is going to include a list of symptoms, often in groups. Okay. And it's also going to include criteria about how many symptoms must be present in each category to justify a label. Okay? And you guys will see this in future videos as we talk about specific psychological disorders. Okay, so what are some of the critiques or criticisms of the Diagnostic and Statistical Manual? Well, many people have alleged that the DSM calls too many people disordered, right? So a fundamental problem with the diagnostic labeling of psychologically disordered behaviors is that the labels often bias our perception of the labeled person, right? So for example, if you know that somebody is diagnosed with depression, right, and you see that person maybe crying or upset, you might automatically assume that that person is crying as a result of their depression, when maybe in reality maybe they injured themselves somehow, or maybe they're crying because they watched a sad movie, right, or something of that nature, right? So the way that we view people once they have a particular label or diagnosis associated with them is going to be different than if we didn't know of that label. There's also been studies showing that teachers, once they know that a student has, for example, ADHD, they tend to assume that they're going to have behavioral issues with that child, and they tend to rate them as less cooperative, less intelligent, less motivated as compared to other students, right? So sometimes labels can have a profound effect on how individuals are perceived. So the first criticism that's listed there that's been raised about the DSM-5 in particular, or our current edition of the DSM, is the possibility that too many people are considered disordered, particularly in reference to depression, right? So it's essentially the argument that, for example, depression is often part of the grieving process, right? And is a natural part of losing a loved one. However, depression, as it presents during the grieving process, shares many of the same symptoms as major depressive disorder. And so because of that, it's more likely to be given a diagnostic label that implies that it needs to be treated. When in actuality, it's a context-appropriate pattern of symptoms that has a definitive cause and doesn't necessarily need treatment. And also, as I think I've mentioned in other videos, there has been very limited evidence to suggest that grief interventions, right, like group therapy or grief-centered therapy, result in better outcomes after the death of a loved one than simply sort of naturally going through that grieving process. So the second criticism listed there is that the border between diagnosis and between disorder and normal sometimes seems arbitrary, right? So that's true of, again, the grief that we would expect with the death of a loved one in major depressive disorder, right? Many of those same symptoms overlap, right? But what we can do to address that criticism and what we continue to attempt to do is to create valid, reliable criteria for a particular disorder. And we consistently conduct experiments and various kinds of studies to make sure that our diagnostic criteria are appropriate. The third criticism is that decisions about what is a disorder seem to include value judgments, right? So, for example, in much older versions of the Diagnostic and Statistical Manual, homosexuality was considered a disorder. However, as of 1972, we have removed that homosexuality from the DSM, and in the current and future versions, we have certainly corrected for that, but there are other biases as well, or there are other value judgments as well. So, for example, there are more labels for symptoms most likely to be evident in females, right? Or there are more diagnoses for symptoms that tend to occur in females and fewer for things that tend to present almost exclusively in males, right? So we have a lot of different diagnoses for things like anxiety and depression, whereas we have relatively few diagnoses for things like anger-related disorders, right? So essentially what that means is that we seem to be more likely to pathologize women than to pathologize men, even though all of these symptoms, whether they be anger or symptoms of depression, can profoundly negatively impact one's daily life in a way that would qualify for, again, symptoms of a disorder. Okay. And again, number 4 kind of goes back to the first one that I talked about, which is that diagnostic labels direct how we view and interpret the world, telling us which behavior and mental states to see as disordered, right? So, one of the examples of how this can happen was demonstrated several years ago in the 1960s when several pseudo patients went into a psychiatric hospital. So these were individuals from a variety of different walks of life, right? So, for example, there was a graduate student in psychology, there was a housewife, there was a very successful businessman, right? And all of these individuals were were instructed to enter a psychiatric hospital, even though they weren't suffering from a psychological disorder, in order to investigate kind of what their experiences were. And what they found is that these individuals were immediately hospitalized because they were instructed by the particular researcher conducting this study to say that they heard a voice, and that this voice said thud. And so the reason why that was chose was because there is no one in the clinical literature at the time who had ever presented with that symptom, a voice in their head that said the word thud. So it was unusual, but it would immediately be considered symptomatic of a delusional disorder, right, to have auditory hallucinations. So it was thought that these pseudo patients, as they were called, would have no difficulty being admitted to a psychiatric hospital. And in fact, they were, okay? But immediately after they were admitted, if they were asked if they were still hearing voices, they would say no, right? So anyway, most of these pseudo patients were immediately given a diagnosis of schizophrenia, and many of their behaviors were interpreted as being symptomatic of that. So these patients were instructed to give their normal life histories, right? So the housewife talked about, her relationship with her husband and her kids. The graduate student talked about his, course of study and what he hoped to achieve in the future. And what was interesting is that the psychiatrist and psychologist at the mental hospital interpreted these, quote, normal patient histories as being symptomatic of their particular disorder. So, for example, the relationship between the housewife and her husband was labeled as being distant and filled with, kind of emotional anguish. And the graduate student would often take notes during group therapy sessions, and that was considered symptomatic of his disorder as well. So even though these individuals did not have a psychological disorder, once a diagnosis had been attributed to them, their behavior was immediately interpreted as being symptomatic of a psychological disorder. Right? So if you guys are interested in hearing more about that study, it was conducted by Dr. Rosenhan in the 1960s. And there are a lot of different videos and internet sites you can go to learn more about it. Okay, so let's return to something that we talked about earlier in the semester, and that's the BioPsychosocial Approach. So in today's psychological studies, right, we attempt to examine how biological, psychological, and sociocultural factors interact to produce specific psychological disorders, right? So basically, the biopsychosocial approach is a general approach that suggests that there are biological factors, psychological factors, and sociocultural factors that play significant roles in human functioning or in the context of disease or illness, right? So what are some of the biological factors that might influence psychological disorders? Well, you might have a genetic disposition, right? So, for example, if your parents suffered from mental illness, it's very likely that you might experience that as well. There are also specific changes in brain structure and biochemistry within the central nervous system that often give rise to psychological disorders, which we'll talk about in future videos when I discuss specific types of psychological disorders. There are also psychological influences, right? So, for example, one of the biggest determinants of a future psychological disorder is going to be trauma, right? So, whether you have suffered physical abuse, emotional abuse, sexual abuse, that's going to be a significant predictor of whether you are later diagnosed with a psychological disorder. Also, the way that our particular mood tends to alter our perceptions and our memories, right? So, for example, if you're suffering from consistent or persistent depressed mood, right, you tend to retrieve memories of sad or traumatic events more than of neutral or happy events. And your perception of, for example, your perception of your relationships with others might be colored as well. So, for example, if a friend doesn't invite you to lunch, instead of thinking, well, maybe she had something to discuss with other people, or maybe she was busy and didn't have time to reach out and invite me. Maybe you tend to think that it's something that you did, or, maybe you make a global attribution that you never get invited out by your friends, and therefore they must not like you, that kind of thing. So again, if we have a significant or persistent depressed mood, that's going to influence what we remember and also how we perceive certain life events. Societal influences. One of these societal influences is going to be the particular roles that we ascribe to, for example, women versus men, right? So women are often perceived as being more emotional and more likely to experience, sadness, whereas men are perceived as much less emotional, but maybe more likely to experience anger. Also, we might have specific expectations for behavior that are going to determine whether they are, whether a particular behavior is deviant or not. And again, whatever our society defines as normal or abnormal is going to influence what eventually is given the label of disorder, right? Okay, so one of the last points that I wanted to make is that there is a very persistent, unfortunately, myth about mental illness that often gets perpetuated in the media, and that is that individuals with psychological disorders tend to be more violent or more likely to commit violent acts as compared to people without mental illness, right? Where in actuality, most people with psychological disorders are nonviolent, and not only are they nonviolent, but they're more likely to become victims than attackers, right? So individuals with mental illness are much, much more vulnerable than individuals without mental illness to be the victim of violent attacks and also the victim of a number of other crimes, as compared to individuals without mental illnesses. Another thing that your book discusses is kind of the factors that make one vulnerable to a psychological disorder. And one of the biggest risk factors is poverty. So a lot of the conditions and experiences that are commonly associated with poverty contribute to the development of psychological disorders, right? And some disorders, such as schizophrenia, are so pervasive and so chronic that they drive people into poverty simply because they are unable to hold down a job and to establish economic stability. Okay, so here are some of the risk factors and also the protective factors associated with mental illness. So like I said, some of the risk factors for developing a psychological disorder are things like child abuse and neglect, family disorganization or conflict, low economic status, parental mental illness or parental substance abuse. There's also things like low birth weight or birth complications, stressful life events, and trauma experiences, okay? So those are some of the biggest predictors of mental illness later in life. But there are also a lot of protective factors, right? So for example, aerobic exercise and general physical health can sometimes protect against mental illness, as can effective parenting and economic dependence, and even things like literacy and social and occupational skills can protect against mental illness, as can social support from one's network of either family or friends. This was kind of just a very brief overview of Module 47, but in my later videos, I will discuss specific kinds of psychological disorders and how they can be diagnosed and treated. So I look forward to seeing you in my next video.